ever thought about how abortions are provided? I mean, who's providing them, in what environments, and what methods? It turns out that this is important to understand when thinking about the current crisis we're in and what can be done about it. I'm Joan Fleischman. I'm a family doctor, and I've been providing abortion care for over 25 years. On behalf of my colleagues, welcome to Maya Network. We hope you'll appreciate our fresh perspective and consider donating to our clinician-led effort. Let's start by taking a moment to imagine if abortion were part of mainstream medical care. This means that you could end your pregnancy in the privacy of your relationship with your clinician, in the same way you would get any other medical care. If many clinicians were offering these services, how would anyone be able to target patients and clinicians with protests, laws, violence, and now, once again, criminalization? To understand our current challenges and what to do about it, it's important to know more about abortion methods and the history of abortion care. In 1973, when Roe v. Wade passed, mainstream medical institutions didn't have experience providing abortions, so standalone clinics were established. At that time, this made sense since all first and second trimester abortions were completed with surgery. Clinics required operating rooms, recovery rooms, and surgeons. Then, in the year 2000, there were two advances in early abortion care that had the potential to integrate it into mainstream medicine. The FDA approved the abortion pill, and also a less-known procedure called manual uterine aspiration, or MUA, was introduced to the mainstream medical community. This simple, gentle procedure could be completed in a few minutes longer than a Pap test in a regular medical office. With these two non-surgical, medically simple methods, abortion care was now fully within the scope of primary care clinicians, family doctors, nurse practitioners, physician assistants, midwives, even pediatricians. Not only could abortion care be more private and personal, but also integration had the possibility of making targeting obsolete. Many of us clinicians worked hard to make this vision a reality. Long story short, there were many barriers, and for the past 20 years, we had limited success in accomplishing this vision. Then, in 2020, there was a leap in healthcare that completely changed access to abortion. Because of the pandemic, there was rapid expansion of telehealth. Poof! Overnight, the FDA lifted its restrictions on how to dispense the abortion pill. This was an important barrier we primary care clinicians had been trying to overcome for over 20 years. Suddenly, we were able to video chat with our patients and mail abortion pills directly to them. Medically speaking, it was easier than ever to help people access abortion, and there was no way to target us. We seized the opportunity to launch Maya Network to help primary care clinicians provide care directly to patients, and also to realize our long-term vision of normalized abortion care. With the Dobbs decision in 2022, everything changed again as we were launched into a public health emergency. In response, abortion pill telehealth organizations expanded rapidly, and some clinicians have been risking everything to get them to people in states where it's illegal. Many of us are a part of these efforts, and we at Maya Network continue our work to change the foundation of abortion care. In states where abortion is legal, we want to normalize abortion care medically. We're inspired by a vision of people having access to abortion as easily as they do to a Pap test. This game-changing approach will assure that abortion care is not vulnerable to unprecedented laws that encroach on our role as clinicians. By demonstrating this integrated model, we hope that it will change how abortion is provided everywhere. How are we doing this? We're working to normalize abortion care both medically and culturally. We're identifying clinicians, giving them whatever support and training they need, and linking patients with them. Most are starting with abortion pills through telehealth, and we're helping them to add MUA where they're able. We're building the boat as we cross the river. Every patient we help also grows our network and advances the entire way abortion is provided. Culturally, we're putting our names and faces and voices forward to talk about abortion as healthcare. And you'll see on our website that our patients are also adding their much needed voices to the conversation. As clinicians, we know that patients count on us. We hope that we can count on you to propel this much needed transformation forward. Thank you.